So, if you were to break your arm right now, you'd probably expect a certain level of, mechanical precision
Mm.
from the
Right,
doctors.
yeah, you just go to a hospital and get it fixed.
Exactly. You go in, the x-ray shows this jagged white line, the doctor points right to it, they set the bone, and you go home. It's a very clean binary problem. It's broken or it's not.
It's very straightforward.
Right. But if you stepped into an oncology ward, say, a decade or two ago to treat a complex internal cancer, that expectation of mechanical precision it completely vanished.
Oh, absolutely. The diagnostic landscape back then was just incredibly murky.
Yeah, and because it was so murky, the treatment was usually this very blunt instrument.
For decades, honestly, the surgical philosophy in oncology was rooted in this kind of radical certainty. Like, if there is a cancer, you just cut it out entirely.
Just get rid of it.
Right. Along with a really wide, generous margin of everything around it, you just didn't leave things to chance. The goal was eradication at all costs.
And the collateral damage to the patient's body was just, viewed as the necessary price of survival.
Yeah, exactly, as a trade-off.
Well, welcome to the deep dive. Today we are unpacking a really massive stack of medical research. Specifically, we're looking at the newly updated ESMO guidelines.
That's the European Society for Medical Oncology, for those who might not know.
Right, thank you. And these guidelines cover the diagnosis, treatment, and follow-up of localized rectal cancer. Our mission today is to show you why that old era of cut it all out is finally coming to an end.
It's a huge shift.
It really is. We are looking at a fundamental philosophical shift in modern medicine. We're moving from that rigid, one-size-fits-all surgical approach into a highly customized, precision-guided strategy.
And incredibly, the ultimate goal of this new strategy is, in a lot of cases, to avoid surgery altogether.
Which is just wild to think about. Okay, so let's unpack this, because even if you aren't a medical professional, understanding the future of personalized medicine is crucial.
It affects everyone, eventually.
Exactly. Especially since the demographics of who actually gets this specific disease are rapidly and quite alarmingly shifting.
Yeah, that demographic shift is precisely what is forcing the medical community's hand here.
Right.
Because rectal cancer accounts for almost 1/3 of all colorectal cancers. It is not a rare occurrence by any means.
Not at all.
But the pivot, the detail that changes the entire calculus of how doctors respond, is the actual age of the patients walking into the clinic today.
Yeah, looking at the data in the guidelines, the baseline numbers are just stark. For every 100,000 men listening to this, about 14 will face this diagnosis each year.
Right.
And for women, it's about 9 out of every 100,000. But what really stands out is that the incidence is rising sharply in the 50 to 64 age group.
Yes, that's the really concerning part.
Right. In fact, rectal cancer now accounts for 4 out of 10 colorectal cancers in that specific demographic.
4 out of 10. I mean, these are patients in the prime of their working lives. And the guidelines explicitly tie this trend to lifestyle factors.
Like what, specifically?
Well, we are looking at the compounding effects of excess body weight, obesity, the consequent diabetes, a lack of physical exercise, and just modern dietary habits.
So it's basically the modern lifestyle catching up to us.
Exactly. And when we talk about those factors, we aren't just talking about, general unhealthiness. We are talking about chronic inflammation and insulin resistance,
Right.
which literally create a cellular environment that actively encourages tumors to grow and mutate.
So is this demographic shift essentially the biological equivalent of, say, putting cheap oil and bad fuel in your car? Like, we've altered our environment and our daily diet so drastically over the last few decades that the engine is knocking a full 10 years earlier than it used to.
If we connect this to the bigger picture, that analogy highlights the fundamental problem facing oncologists right now.
Because the engine is knocking early.
Right. When the engine starts knocking a decade early, the mechanics approach has to fundamentally change. When a patient is diagnosed in their early 50s, the medical field is forced to think about the next 30 or 40 years of that patient's life.
Because the traditional surgery for this total mesorectal excision, or TME, is just deeply life-altering, right?
Incredibly disruptive.
The guidelines keep mentioning this standard surgery, but what are they actually doing in a TME that makes it so tough on a patient's life?
To understand the disruption, you really have to picture the anatomy. The pelvic cavity is essentially a bony funnel.
Okay.
It is an incredibly tight, crowded space, And it's packed with these microscopic autonomic nerve clusters.
And those nerves control pretty much everything down there.
Exactly. They control the bladder, the reproductive organs, the entire lower digestive tract. So in a total mesorectal excision, the surgeon is removing the rectum and the surrounding envelope of tissue.
Wow.
And to do that, they are navigating just millimeters away from those critical nerve networks.
So basically, cutting out the rectum almost guarantees some level of collateral nerve damage.
It carries a massive, massive risk. We're talking about potential lifelong issues with anorectal function,
Right.
which frequently requires permanent stoma bags where waste is routed outside the body.
That's a huge lifestyle change for a 50-year-old.
Massive. And we are talking about severe impacts on genitourinary function, which translates directly to sexual dysfunction and incontinence.
Wow.
Historically, as we mentioned earlier, surgeons viewed that as an acceptable trade-off for getting the cancer out.
But you can't just apply a brutal, life-altering surgery to a 50-year-old if a more elegant, organ-preserving solution exists. I mean, they have to live with those consequences for decades.
Exactly.
So if we agree that we can't just indiscriminately hack away at a patient's pelvic cavity, how do doctors know exactly where the safe boundaries actually are? That seems like a massive imaging problem.
It is a monumental imaging problem,
Right.
which is exactly why the guidelines now mandate a multidisciplinary team, or MDT, for every single patient right from the moment of diagnosis.
So no more lone wolf surgeons.
The days of a lone surgeon making the call in a vacuum are totally over.
I really love reading about this specific requirement because it sounds a bit like a highly specialized heist crew from a movie.
It really does.
You know, you don't just send in the muscle to surgeon and just hope for the best. You need the surveillance expert, which is the radiologist.
Right.
You need the hacker, the geneticist, and you need the mastermind, the medical oncologist. They all have to sit at the exact same table, analyzing the exact same data to pull off the job.
And the pathologist and radiation oncologist are at that table too. They all serve as checks and balances for one another.
That makes a lot of sense.
And the surveillance data they are reviewing together has fundamentally changed. The ESMO guidelines explicitly state that MRI is now mandatory for staging the disease.
Oh, mandatory.
Yes, it has largely replaced the old rigid rectoscopy, which was essentially just a visual inspection tube.
I did notice in the sources that while MRI is the absolute gold standard for mapping, they also still recommend endorectal ultrasound, or ERU, in certain cases.
Yeah, they do.
But if the MRI is so incredibly good at mapping the pelvis, why use an ultrasound at all? It seems kind of redundant.
Well, what's fascinating here is how these tools actually complement each other based on what you specifically need to see. Think of the ultrasound as a high-powered magnifying glass.
Okay, a magnifying glass.
It is exceptional for looking at the immediate microscopic surface. It actually outperforms MRI when the team is trying to distinguish the exact depth of early localized tumors.
Like telling the difference between a shallow and a deep tumor.
Exactly. For example, differentiating a T1 tumor from a slightly deeper T2 tumor.
Right, and for context for you listening, T1 means the tumor is just restricted to the inner lining, the mucosa, but T2 means it's starting to dig a bit deeper into the actual muscle wall.
Right.
So the ultrasound basically tells you exactly how deep the roots of that weed go right at the surface.
Precisely. But the magnifying glass can't see the whole yard.
Oh, I see.
That's where the MRI comes in. The MRI is the drone mapping the entire pelvic landscape. It's looking for high-risk features to see if the cancer is reaching toward the physical borders of the neighborhood.
Like the outer edges.
Right. Specifically, the MRI can see if the tumor is invading the mesorectal fascia. The MRI is basically the outer protective envelope of tissue surrounding the rectum.
Okay, the guidelines also highlight things like EMVI and enlarged lateral lymph nodes as major red flags that this MRI drone is looking for, but I don't think I fully grasp what EMVI means in practical terms.
So EMVI stands for extramural venous invasion.
Okay.
It simply means the cancer is physically broken into the blood vessels outside the bowel wall.
Oh, wow. So it's getting into the transit system.
Exactly. And the lateral lymph nodes act as the body's drainage filters. The MRI drone is scanning the pelvis for any lymph node that is 7 millimeters or larger.
7 millimeters is the cutoff.
Yeah. If the multidisciplinary team spots those markers, fascia invasion, EMVI, or enlarged nodes, they know the cancer is trying to spread. They can't just go in with a standard surgical plan. They have to escalate the strategy.
Okay, so once this heist crew has perfectly mapped the tumor, identified the depth with the ultrasound, and checked the borders and blood vessels with the MRI, what is the actual play?
Well, historically, the answer was immediate surgery. You see the tumor, you cut it out.
Right.
But this is where the guidelines introduce a massive paradigm shift. What if they hit the tumor with drugs and radiation first, and the tumor just, disappears?
Right, disappears completely?
Yes, this is the concept of total neoadjuvant therapy, or TNT. Instead of doing surgery first and maybe cleaning up with chemotherapy afterward, the strategy completely flips.
Okay.
The team delivers systemic chemotherapy and localized chemoradiotherapy before any surgery takes place.
The logic there makes a lot of sense, but why hit it with both chemo and radiation first?
Because cancer isn't always just a local problem. TNT uses systemic chemotherapy to sweep the entire bloodstream for microscopic stray cells that might have escaped,
I get it.
while the radiation acts as a localized hammer on the primary tumor itself.
And the sources reference major clinical trials backing this up, right? Like the Rapido and Protégé 23 trials, showing that this TNT approach actively improves disease-free survival.
Yes, the data is very strong.
But the part that really catches my attention is what happens when the treatment overperforms. Sometimes the TNT works so well that the patient achieves what the medical community calls a CCR, a clinical complete response.
Exactly.
Meaning there's literally no tumor left to cut out.
And that leads to the most radical recommendation in the updated guidelines, the watch and wait approach.
Watch and wait.
Right. Backed by the OPRA trial and the International Watch and Wait database, if a patient achieves that complete clinical response, they can skip the life-altering total mesorectal excision entirely.
Wow. So they avoid the stomas, they avoid the sexual dysfunction, they avoid the incontinence, they get to keep their normal anatomy.
Yes, all of it.
But I really have to push back here. Leaving a cancer alone just because we can't see it on a scan, that sounds absolutely terrifying for the patient.
It is a huge mental hurdle.
Isn't that essentially like putting a piece of black tape over the check engine light and just assuming the car is permanently fixed? How do oncologists justify the risk that a few microscopic cells might just be hiding?
This raises an incredibly important question, and it addresses the massive psychological toll of this approach. It is exactly why watch and wait is not a passive strategy.
So they aren't just sending them home and saying good luck.
Not at all. It is not blind hope. It is active, highly aggressive surveillance. The guidelines mandate a grueling, intense follow-up schedule. We are talking about a full MRI and an endoscopy every 3 months for the first 2 years.
Every 3 months. That is a lot of hospital visits because that 2-year window is the danger zone, right?
Yes, exactly. The OPRA trial demonstrated that 94% of recurrences, or what they actually call regrowths, happen within those first 2 years.
Okay.
And the reality the patient must accept is that there is a 25 to 35% chance of a regrowth occurring.
Wow, over a quarter of patients will see the tumor return. That is a really significant gamble to take with your life.
It is a calculated risk, but the clinical data provides a very robust safety net. If there is a regrowth caught during that 3-month surveillance window, salvage surgery, meaning doing the radical removal later, is highly effective.
Okay, so they can just go in and get it later.
Right. The 5-year disease-free survival rate for someone who does watch and wait, experiences a regrowth, and then needs salvage surgery is 64%.
And how does that compare to the patient who just opts to do the radical surgery right away on day 1?
It's essentially the exact same.
Wait, really?
Yeah, the survival rate is 64% either way. So you are taking a rigorously data-backed risk.
That's fascinating.
If the watch and wait works, you save the patient's normal bodily functions for the rest of their life. If it fails, you haven't actually lost ground on their overall survival chances.
That is a phenomenal trade-off when you understand the mechanics behind the numbers. You're trading intense, frequent hospital visits and, scanxiety for the chance to keep your body perfectly intact.
Exactly.
But total neoadjuvant therapy and watch and wait are designed for standard, typical tumors. What happens if we zoom in even closer, like down to the actual DNA of the tumor itself?
This is where things get really incredible.
Because for a very specific subset of patients, the treatment protocol gets even more sci-fi. They can skip the chemotherapy and the radiation entirely, right?
Yes, this is the true frontier of personalized medicine right now. The guidelines now strictly mandate that every single patient must have their tumor's molecular biology tested right at diagnosis.
Oh, right at the start.
Using the initial biopsy material. You simply cannot wait to do this.
Because the heist crew is hunting for a very specific genetic glitch, I read that about 2 to 3% of rectal cancers are mismatch repair deficient, which the guidelines refer to as DMMR.
Right.
Or similarly, they have high microsatellite instability, known as MSIH. What do those acronyms actually mean for the biology of the tumor?
Okay, think of mismatch repair, or MMR, as the cellular spell checker for your DNA.
The spell checker.
Right. Every time a cell divides, it has to copy its DNA, and sometimes it makes a typo. The MMR system spots the typo and fixes it immediately.
Makes sense.
But in these 2 to 3% of patients, the spell checker is completely broken. Mutations pile up rapidly. That's microsatellite instability.
Okay.
Paradoxically, having a broken spell checker makes these specific tumors highly resistant to traditional chemotherapy.
Oh, really? Because standard chemotherapy is a bit like a carpet bombing campaign, right? It relies on disrupting normal cell division.
Exactly.
But if the DMMR cells are already playing by entirely different chaotic rules, the chemo just doesn't work well on them.
It doesn't. It subjects the patient to systemic toxicity.
Hmm.
Hair loss, nausea, immune system crashes for very, very little clinical benefit.
So because traditional chemo fails here, oncologists tried something entirely different. They used a drug called dostarlimab,
Yes.
which is a PD-1 blocking immunotherapy. The mechanism here is just brilliant. Cancer cells survive by using a biochemical fake ID, this PD-1 pathway, to tell the body's immune system, hey, I belong here, I'm a normal cell, don't attack me.
That's a great way to describe it.
And this immunotherapy drug basically shreds that fake ID. Once the brakes are off, your own immune system recognizes the highly mutated tumor as a foreign invader and does all the destructive work for us, leaving the healthy city completely untouched.
And the results of the phase 2 trial for dostarlimab are, frankly, some of the most astonishing data ever published in modern oncology.
Really?
Yes. They gave this drug for 6 months to patients with locally advanced dMMR rectal cancer.
The source material says 42 out of 42 patients achieved a 100% clinical complete response. Let me just repeat that for you listening. 42 out of 42, 100%.
It's unheard of.
That isn't just a successful trial. That is an unprecedented statistical anomaly in the history of cancer research.
No surgery, no radiation, no standard toxic chemotherapy at all, and 0 clinical progression after a median follow-up of over 26 months. The tumor simply vanished.
Wow. It really underscores the absolute gravity of the diagnostic phase.
Which highlights precisely why that upfront molecular testing is a non-negotiable requirement in the guidelines now.
Right.
Missing that dMMR marker isn't just a bureaucratic oversight. It means subjecting a patient to months of toxic radiation, ineffective chemotherapy, and potentially a life-altering pelvic surgery that they fundamentally never needed in the first place.
So what does this all mean for you listening? Let's synthesize this entire deep dive. We started by discussing how treating this disease used to be a really blunt instrument, a rigid, almost mechanical expectation of, see the tumor, cut it all out.
Yeah, the old way of doing things.
But what these ISMO guidelines reveal is that rectal cancer management has evolved into a highly choreographed, multidisciplinary science. We've moved from cut it out to precision drone mapping with MRI and depth profiling with ultrasound.
It's a completely different landscape.
We're using total neoadjuvant therapy to shrink standard tumors before a scalpel ever touches the patient. We are utilizing data-backed watch-and-wait protocols to actively preserve human organs. And at the very cutting edge, we are using targeted immunotherapy that shreds the cancer's fake ID and erases specific genetic variants of tumors entirely.
And it all circles back to that initial demographic shift we discussed at the very beginning.
The younger patients.
Right. Because patients are younger, facing decades of life post-diagnosis, the medical community has recognized that eradicating the disease at the expense of the patient's anatomy is no longer the only metric of success. Quality of life matters just as much.
For you listening, the value of being informed about this is immense. Modern medicine is now as much about preserving how you live as it is about extending how long you live.
Absolutely.
That expectation of precision, that clear X-ray we talked about at the very beginning, we might not have it perfectly yet, but the muddy waters are definitely clearing. We are finally trading in the blunt surgical instruments for something far more refined.
And that leaves us with a fascinating, almost provocative thought to ponder. If a 6-month course of immunotherapy can completely eradicate a localized rectal tumor without a single surgical incision, without a single drop of radiation for a specific genetic profile,
Yeah.
how far are we from a future where surgery for any localized cancer is viewed not as the standard first line of defense, but as a medieval last resort?